Okay, everyone, welcome back. This is part 3 of the breastfeeding education. We're going to focus on pumping and supplementing in this section. So I'll share my screen. When is it time to start pumping? The goal is basically by 6 hours of life if it's indicated. So if the baby requires a supplemental feeding for any reason, anytime that baby requires a supplement, mom should be pumping because the baby did not get enough to eat from mom, whether it be because the baby didn't latch or the baby's not good at removing it. If the baby does need a supplemental feeding, though, mom should be pumping. So again, if the baby's having difficulty achieving or sustaining a latch, if the mom is too painful, if the baby can latch, but she just can't tolerate that pain, it might be necessary to pump instead. Again, knowing that the baby may not be quite skilled yet, the baby may be causing the pain, but also once in a while you encounter a breastfeeding parent who just has a very, very difficult time tolerating any breast stimulation. So the pump can be a good way to check for that. You can adjust the settings with the pump. And if she has a hard time handling even the lowest setting, we may have to have a conversation about what her expectations are and what her goals will be with feeding. Obviously, if the parent and the baby are separated, whether the baby's in the NICU or the nest or some other part of the hospital, mom should always be pumping at that point. And there is research to show that people who start pumping within the first hour can make twice as much milk. So again, think of it as the golden hour. If you're caring for somebody, say in the OR setting and the baby goes straight to the nest, you want to make sure that mom's getting pumping as soon as possible. And I know the PACU can be a difficult place to get people pumping. You're limited on space and you may not even have our electric pumps back there, but know that the manual pumps are very effective as well. So if you are limited on space, at least find her a manual pump. You can even give her 2 manual pumps so she can do 2-sided pumping, but she should ideally start pumping in that first hour, treat it as the golden hour. And if baby's not there to make a latch, then we would use the pump instead. So as a nurse, you can make a big difference. Try to locate a pump and set that up for her. Again, it's a big unit and you're kind of stuck where you are with your patient. So you may not have the ability to walk the whole floor and find a pump. That's where we can help. If you are having difficulty locating a pump, we typically have enough on the floor. We can go find one in an empty room or some other hiding place. A worst case, we can always order another pump through MSC. But if you're challenged to find a pump and you can't leave your patient, page Lactation and we can see if we can find one for you. Always instruct the parents on operation and cleaning. We'll talk about that really quickly. When you're setting someone up to pump, let me switch back so you can see here. I just want you to see when you're setting someone up to pump, the supplies that you'll want to get. So you'll want to get a basin. This will be for her to clean her parts in. You'll get a breast pump kit. It comes in a package, but it's basically a 2-sided pump kit with the tubing. You want to get some kind of blue cloth or drying cloth that you can dry the equipment on. If these are available, try to get the smaller bottles. The pump comes with these bigger bottles, but again, thinking the psychology of breastfeeding, she's not going to fill this with colostrum. So if we can switch it out to the smaller bottles, you know, a little bit of colostrum in here looks like a lot more than it does in here. So psychologically, the small bottles can be helpful. It's also a little easier to draw up what you do get there. So get the small bottles, switch the pump into those, and then a bottle of palm olive. We want to make sure and wash the pump parts with palm olive. If for some reason this is out of stock, we do have baby soap as well. For 1 or 2 uses, that would be okay. But for long-term use, that does break down the pump parts. It builds up a residue. So the palm olive is recommended for cleaning. So to set someone up to pump, you'll get the kit, connect your small bottles, and then I brought one of our electric pumps in. I think there's a little bit of confusion. Let's see if you can see that a little better. A little bit of confusion on how to operate this, how to set it up. So when you've got your kit, it's going to plug into the hole up front here. And then there are little stands on the top where the bottle can rest or the flange can rest, either way. I don't have it plugged in, but you would power it on here. This is the power button. And then this machine has a speed setting, a suction setting, and a timer. So if you ever forget, there are little cards on each pump that instructs you how to use it. The recommendation for the speed is anywhere from 40 to 60. The recommendation on the suction is 25 to 50. And the timer, we would want to run it for about 15 minutes. That's a lot of detail and a lot of information, and a lot of our parents are sleep deprived, so they have a hard time remembering that. So if you want to keep it simple for them, I would recommend a speed of 40, suction of 40, and timer for 15. So 40, 40, and 15. And then if it's too painful, she can drop her suction a little bit to what's more tolerable. But you just want to run it at a good steady speed and a suction that's strong enough but not painful, and for a good 15 minutes, and then she'll turn it off. At the end of the pumping session, be sure to set her expectations that she is not going to have a bottle full of breast milk yet. She's only making colostrum. If it's her initial time, she may see a little spillover into the bottle, but what's realistic is really just some drops of colostrum here, just a little sticky residue. If that's all she sees, she can wipe that with a finger and put it in the baby's mouth. Some of the colostrum will pool in this little flange area. She can pinch that onto her finger and feed the baby. If there's a little bit in the bottom of the bottle, she can use a syringe to draw the colostrum up from the bottom of the bottle. But then I would not feed the baby from this. I'd put it to a spoon and spoon feed the baby. So just be sure, most importantly, to set her expectations appropriately, that we're pumping for stimulation. We'll get some colostrum, probably just drops. Whatever we get, we'll feed the baby. If we need to feed the baby more volume, we'll have to intervene with some formula if we don't get enough for mom. Many parents will see an initial surge of colostrum on day 1, and then they progressively see less and less, kind of a dry spell on day 2 until their milk starts coming in. So again, expectations are important. The recommendation for pumping, again, if her baby's not latching, at least every 3 hours for 15 to 20 minutes, both sides. When would it be indicated to do a supplemental feeding? Keep in mind there are medical and behavioral indications. So the medical indications are going to be things like that small population, that early population we talked about earlier. There is a feeding plan. It's called Feeding the Baby Born Before 38 Weeks. You're able to access that from the grease board in MyChart. When you're in the grease board, if you just go in the upper bar, upper right-hand corner, there's a UMHS drop-downs link. Hit the drop-down and it says Patient Education Clearinghouse. In that clearinghouse, if you just search breastfeeding, you'll get every breastfeeding document that we've ever written. And in there is the Feeding the Baby Born Before 38 Weeks. It outlines how much the baby should be taking for each day of life. It recommends pumping every 3 hours. That document is also translated in 5 other languages: Spanish, Japanese, Chinese, Arabic, and I think Korean. So if you're taking care of a non-English speaking family, you may be able to use one of those documents as well. But again, those medical indications would be less than 38 weeks, less than 2,500 grams, if they are not able to effectively latch or sustain a latch by about 6 hours of age. Hypoglycemia is listed as a medical indication. That is a gray area. We have our new hypoglycemia protocol, and in the protocol, it mentions attempt of feeding, and it also recommends glucose gel as the treatment for low glucose. So again, know that the hypoglycemia protocol is a screening protocol for hypoglycemia. Aside from that, you've got your 2 populations of infants. So if you are using the hypoglycemia protocol because the baby is less than 2,500 grams, that's a baby we know is going to have feeding challenges and would be recommended to be supplemented based on its feeding plan. So you'll still screen for hypoglycemia. You'll still treat with glucose gel if the sugar is low. But if that baby is not able to latch or sustain an effective latch, the feeding plan does recommend supplementing. You're supplementing because the baby is born small, and especially if the baby has a low glucose. If you're taking care of a full-term, normal-sized baby who was born to a diabetic mother and you're screening for hypoglycemia for that reason, if that baby has a low sugar and you treat it with glucose, but that baby latches well and feeds well, there's no need to supplement that baby. If that baby has stable glucose, there's no need to supplement that baby. Again, that is a full-term, normal-sized baby. There is no feeding plan that recommends supplementing that baby as long as the glucose is stable. If the glucose is not stable and the baby cannot latch, we would also recommend supplementing that baby. So keep in mind, you've got your 2 populations and your hypoglycemia screening protocol. The screening protocol is really there to determine the babies who are unwell. So if we know babies typically have a decrease in their glucose in the first few hours of life. If they have that transient decrease and we treat it with glucose gel and it recovers and then they sustain, then they are a well baby. If they have that decrease and we treat with gel and we treat with gel a second time and they're just not maintaining their glucose values, they're an unwell baby. And that's the point of the hypoglycemia screening protocol, is to screen for the baby who is not able to sustain their glucose values. So I know it's gray. If you have questions, you can see one of the educators or one of the lactation consultants, but I hope that helps a little bit. Another reason to supplement would be no latch or a difficult latch when the baby is over 24 hours old. So again, we try to give the babies 24 hours as a free pass to just transition to life, again, for the well, normal, healthy newborn above 37 or above 38 weeks and above 2,500 grams. But if they've gone 24 hours and they still aren't having an effective latch, we need to start doing more. So we'd want mom pumping, and we'd be recommending a supplement at that point. Those are all the medical indications. Hyperbilirubinemia sometimes can come into play too. So if the baby's having any medical reason for a supplement, that would be one indication. The other pocket of indication is behavioral indications. And these are really what we focus on when we're educating parents. Parents aren't monitoring their baby's weight. They aren't monitoring their baby's glucose values, but they are able to monitor behavioral cues. So we want to talk about hunger cues. We want to talk about signs of satiety. And if the baby is still showing hunger cues after a feeding, the parents need to know to supplement that baby. A good deep latch and active sustained suckling for at least 10 minutes or more, even if it's just on one breast, can be considered a normal feeding. If the baby's gone a full half an hour on one breast, we would recommend switching to the other side. And if that baby has fed from both sides for a full half hour on each side and is still showing hunger cues, you have to assume the baby's not being effective at removing milk, or possibly the mom's milk supply is too low. More often than not, it's the baby's technique. So those would be behavioral reasons to introduce a supplement. Again, those are the times, sometimes babies are cluster feeding, and those are the times that get frustrating for parents, and they may want to give a pacifier. They may feel like, I just fed the baby, she can't possibly be hungry. But if she's doing ineffective feeding at the breast and still truly hungry, it doesn't help to give her a pacifier. So watch your hunger cues. A baby who fed well should look relaxed and content at the end of their session. If they're still showing active hunger cues, chomping on their fists, bringing their hands to their mouth, they're still hungry. We have to treat it as hunger. And if they've already maxed out their try at the breast, we need to consider a supplement at that point. Again, preferably mom's milk. And if it's not enough, then introducing formula. When would supplemental feeding or formula not be indicated? For cluster feeding. So cluster feeding is really common with newborns. It tends to be most common overnight. It helps if you ask mom if she can recall when her baby was active in the womb. Most babies are pretty, comfortable and quiet during the day, and then they're much more active at night. When they arrive here, they stay on that same pattern. So they're very sleepy throughout the day and tend to be very active at night and want to do frequent feedings because of that. Again, they have very small stomach capacities. They eat and empty their belly very frequently. So they do need frequent feeding, sometimes as often as every hour. So again, if the baby's showing clear hunger cues, eats well at the breast and looks content, but then wants to eat again in an hour, that would be cluster feeding. If the baby ate well at the breast, came off the breast, still showing hunger cues, that's not cluster feeding, that's ineffective feeding. So helping the family know the difference. Keep in mind gas pain too. Gas pain can present just like hunger cues. So if the baby has discomfort in the belly from gas, they may chomp on their hands. They may bring their hands to their mouth. Then when you go to offer the breast, they're very resistant at the breast. They push away from the breast. They may cry a little bit, draw their arms and legs up, make grunting noises. So if you're seeing those kind of things, you're never wrong to offer the breast first. If the baby's showing cues that they're hungry, offer the breast. But if the baby's really resistant and pushing away, especially if this is a baby who's been sneezing, spitting, gagging, they're probably not ready for food. And you should talk about gas pain with the parents and burping techniques. And then of course, the sleepy, disinterested baby, that's not a baby who needs formula. If the baby is disinterested at the breast and it's less than 24 hours old, you still want to encourage parents to attempt every 3 hours. But it's very much within normal that baby may not be ready or interested in eating. Again, especially if it's very gaggy and spitty. If its little tiny tummy is full of amniotic fluid, it's trying to spit up that fluid before it makes room for food. So offer the breast, attempt, encourage mom to practice her positioning every few hours. But if the baby's not latching, they're simply not ready. Give her reassurance and encouragement and remind her about rest and recovery. Again, that's for the well, healthy, normal newborn. This is the hand expression technique. If you have not practiced this, I encourage you to practice. It can be difficult, and you're only going to get small drops of colostrum. There's an excellent video. There's a link down here. It's a little bit long, but it's in the Get Well network. I'll try to pull it up here. Let's see. if I can pull it up, it comes from Stanford University. I'll start it, and we won't watch the whole thing. It's about 10 minutes long, but I'll try to scroll forward just to the technique so you can watch. This is a nice demonstration.
A soft baby brush or a warm towel. It'll help get the milk beginning to flow. Already we can see just with that.
Oh yeah.
That just the massaging. Exactly. That's really good. Place fingers an inch away from the areola, making a C. Band-Aid markers make it easy to remember finger placement. I'm not going to get my fingers down here with a C. I'll keep them here so that the nipple is in the middle of my thumb and my pointing finger. Apply steady pressure inward towards the breasts, never massaging outward towards the nipple or the spoon. So back and then very gently together. And back and very gently together. And I don't expect to see anything in the beginning. So just know that in the very beginning, even when the baby nurses, she doesn't get anything. She's just beginning to sort of stimulate the milk to let down. And then, and the reason I just go very gently is so your breasts get kind of used to it first. And rather than stay on one breast, I go back and forth. So I go from the right to the left, to right to left, and back and forth. When I push back, I don't tighten up the skin, the dark skin. I don't pull like this. I just go straight back and together, and straight back and together. And then we'll get the milk flowing a little bit, and then I'll show you how to do it. And then we might as well start collecting a little bit.
Yeah, sure.
So remember, when you try to do this yourself, that in the beginning, the milk didn't come very easily. And now it's coming very easily. Okay?
So that's the hand expression technique. And it's really helpful if you're trying to supplement a baby, especially. You can see the minimal amount that comes out is just drops of colostrum. So if this mom were using a breast pump, this small amount of colostrum will get stuck in the pump parts and it'd be really hard to capture. Where if she's able to just hand express straight to the spoon, she's going to capture all that colostrum and be able to feed it to her baby. It's also really important for the mom who has questions about her milk supply or feels like she's not making anything yet. If you can do hand expression and show her that something's coming out, it does a lot for her confidence to realize that her body is working fine. And again, talking about stomach capacity and showing her what would be an appropriate volume for her baby. So this is a really important technique. If you don't feel comfortable with it, I encourage you to practice and just find a patient that you feel comfortable assisting. And the more you do this, the better you'll get at it. It should not be painful to the mom. Also, if she's not comfortable herself or not skilled herself, sometimes if she has a partner who's willing to assist in the room, the partner can help as well. So just keep it in mind as a really helpful technique for capturing colostrum to feed the baby. Talking about stomach capacity, this is a nice little chart that shows you here on day 1 in bottle form, you can see how little there is. It's only about 5 to 7 milliliters. By day 3, it increases to about 30 milliliters. By the end of the first week, it's almost doubled to 60 milliliters. And by the end of the first month, the baby's taking anywhere from 2.5 to 5 ounces of milk. This is the same story with mom's milk supply. It starts very, very small as colostrum and slowly increases. So I'm going to switch slides here just for a second. We have these, we wear them on our lanyards, just these little belly beads. And this is what we show parents to show them the size of their baby's tummy. We've made these as well. These are just little belly beads that you can hook onto your badge if you'd like. I think we used to pass these out in the class, but we'll put these in, the lactation group shares the office with the educators on the birth center floor. So we'll try to make them available. If you'd like one, come to the office and we can try to get you one of those. But those are helpful to show parents what's appropriate for expectations for baby's belly. This is another tool that comes from Medela. This again is the day 1 belly, just this little tiny space. This is by day 3, a little bit bigger. And then this is by day 7. So you can see the change in belly capacity. And this day 7 capacity, they estimate to be about 51 milliliters. I think what's important to note is this is how our formula supplements come. This is 60 milliliters. It's about a day 7, milk volume. Where if we're bringing this to a parent on day 1 and putting a nipple on this bottle and feeding the baby, we're putting all this volume in this little tiny space. This baby's going to be throwing up, gagging, disinterested in breastfeeding. So it's important to not serve from this bottle, to pour into a shorter bottle, a more appropriate serving. So I would always try to get the shorter bottle in the nipple. And on day one, anywhere from 5 to 10 can be a normal volume. So open this, pour it into here, just your 10, and then you can cap this and store it for later servings. So just remember that in terms of stomach capacity. So how do we offer supplemental feedings? There are different ways we can do that. I think I'll switch back. We're not going to watch the video, but I'll switch you back and just show you some of our different tools here. Typically, again, if you're doing hand expression, you're going to express the milk into the spoon. And then when you're working with the baby, just kind of get the baby in an upright position, shimmy the colostrum down to the tip and just touch it to baby's lip. Usually most babies will pull back at first, and then when they get a taste, they'll come forward and they'll either close their lips on the spoon and sip from it, or they'll just lick from the spoon to take the colostrum in. By the end, you may be tipping up a little bit, but you never want to just pour into the baby's mouth. So spoon feeding is really the recommended method of feeding on day one, especially with colostrum. When you're getting into formula, if you have to introduce formula, formula can be really sloppy on the bottle. It spills out of the baby's mouth, goes down their neck. So if you're moving to formula, you may want to move to a bottle feeding. In which case, again, the volume is important, just a small serving of what's appropriate for the day of life, and then sit the baby again upright and hold that bottle straight. So the idea here is that the baby's in control of their feeding. They're going to take a nice, slow meal. When they're finished eating, they'll stop sucking. They'll only suck as long as they're hungry. You may have those little tiny early babies who need a little help. If you're doing this, you may have to give a little chin support to get them started. But again, once they get started, they'll usually stop on their own. So we're not force feeding. If the baby's on their back and we tip the bottle upside down, they have no choice but to keep sucking, and we're force feeding that baby a volume that they may not need. So sit the baby up, hold the bottle straight. That keeps them exerting some effort in their feeding and able to stop when they're full. That will have partial formula, partial air when they're eating, so they will be gassy at the end. They'll need to be burped. Do try to teach parents how to get a deep latch with the bottle. A lot of parents will offer the bottle just here and the baby's pinching on the tip. So try to get that deep in the baby's mouth. The baby should have a deep latch on the bottle, just like they will with the breast. So that would be bottle feeding. There are a couple other supplemental feeding tools. Again, the syringe, we wouldn't recommend feeding by syringe for a couple reasons. One reason is there is a slight risk for aspiration. If parents push the fluid too quickly, the baby could choke or aspirate. But more often than that, for lactation, what we worry about is the baby isn't really learning to suck with this technique. You're just filling the mouth with fluid and all the baby has to do is swallow. So use the syringe to draw up your colostrum from the bottom of a bottle, but then move it to a spoon. Move your colostrum to a spoon and spoon feed the baby instead. The other tool we have, this is called a supplemental nursing device, and I don't know if you've seen this. You won't see it used too often. The best indication for this is if you have a baby who is indeed latching beautifully at the breast, latching and eating really well at the breast, but for whatever reason still losing weight, or maybe the hypoglycemia, there's some reason that the baby needs additional supplement. This can be a great way to supplement the baby right at the breast. So the way you set this up, it comes with there's a little filter device in there. You'll pour your volume that you need in here, connect the two. This is just a rubber band that clips on the bottom. It's designed to clip about at shoulder height for mom. It's a gravity flow system, so if she clips it really high, it's going to flow really fast. So clip it about to her shoulder or her pillowcase here. There's a clamp here. You'll close the clamp. Squeeze here to get some formula into the tubing. Prime your line like you would an IV line. Get formula or breast milk all through the tubing. And then when you're ready to assist the baby, if this is a breast and the baby's latched well and the baby's eating well, the best way I find is to just pull back on baby's cheek and feed that tube in through the side of the mouth. But the basic idea is that tubing is going to run right along mom's nipple. So then when the baby's latched here, and the milk is flowing, the baby's getting their supplement right at the breast. It's an excellent device, again, for babies who latch well. This should not be used to initiate a latch for a baby who's having difficulty. The baby should already be latching well, but requires additional supplement before you're using this tool. The other indication could be a finger feeding, where you put the tubing along the finger. You have some parents who do not want their baby to have an artificial nipple, so you can do a finger feeding with the tubing at the end of your finger and just have baby suck your finger with the tubing there. So that is a supplemental nursing device. Couple things to know about this. The tubing is so thin, you can't clean it very well. The device has to be replaced every 24 hours. This is only intended really until mom's milk is flowing. So if we discharge someone using this device, we would send them home with a couple to carry them over until her milk is flowing. If she's still having difficulty at that point, we would refer her to the outpatient clinic. Other companies do manufacture longer term use, and you'll see these used sometimes adoptive parents or sometimes even same-sex couples who have a baby, one delivered the baby, one is breastfeeding. They may use a device like this long term. So they do manufacture them for long-term use. Our models are only used for 24 hours or less, and then we should pitch it and replace it. These are available in the stock room. Please don't introduce this on your own. If you think you have a family who could benefit from this, it's an indication to get lactation involved, and we'll see if it's an appropriate solution for them or not. So that is a supplemental nursing device. Two other supplemental techniques. These are specialty feeders. Once in a while, we'll have a baby with a cleft lip or cleft palate. Speech comes up and does a suck swallow assessment with them, and we'll prescribe a feeder. This is called a Haberman feeder. This is a Dr. Brown bottle. Dr. Brown seems to be the favored model lately, and speech language will go through the family a demonstration of how to use that. But occasionally, holidays, weekends, overnight, the baby may deliver when SLP is not available to do their consult. We do stock these in the lactation office. So if we need to get involved to get a baby started with this, we can do that. The Haberman, I think, just to point out, the design is really longer so that it goes deeper in the baby's throat. They just have to exert a little bit of compression here for the milk to flow through. So a baby who's compromised with cleft lip or cleft palate may benefit from this. Oftentimes, if it's only the lip that's cleft, we can, with positioning, seal that lip off enough that the baby can get a good seal, and we'll not have to use a specialty feeder at all. So those are different methods of supplementing your baby. This is just, again, a still shot of the PACE bottle feeding position. We do have a handout in the admission folder that parents get. So if they do have to supplement at home, baby sitting upright, bottle is straight. Storage guidelines, again, in their admission folder, they have a handout with the storage guidelines. Room temperature, breast milk can keep for 6 to 8 hours. It can keep in the refrigerator for 5 days, and it can keep in the freezer for 3 to 6 months. If they Google breast milk storage guidelines, they'll find a whole variety of guidelines. So typically, we're always trying to simplify some of the education because everyone is so sleep deprived. But if you think the rule of fives, breast milk will always keep for 5 hours at room temperature, 5 days in the refrigerator, and 5 months in the freezer. That number keeps them very safe. It often goes a little longer than that, but the rule of fives can help simplify things for families. And then formula, if it's at room temperature, it should be discarded after an hour. If it's a clean pour, if we've opened this bottle and just poured into another bottle, baby's mouth was never on it, it can be stored in the refrigerator for 24 hours. But anytime the baby's mouth has been in contact with the fluid inside, whether it's breast milk or formula, we would recommend discarding that after an hour. And then know that if your baby is off the unit on another floor, the clerk can print out baby labels for you. So if mom has been pumping and expressing milk, even if it's just in a syringe, she can label that and send it down to the milk room or take it down to her baby. I think that ends our session 3. So I'll stop that here. And then our last session is the section 4, and that's just our wrap up and a couple case scenarios. So I'll see you in a few minutes for that.